equivalent to that of the U.S., and they're following the same directional pattern. When you look at black and whites, we have an extraordinary difference between blacks and white males. And while the gap is closing only slightly, it's not closing very much at all. And this is equivalent to what we see at the national level. This is the two bar graphs to give you an idea. So the mortality for black men from prostate cancer is almost 3 times higher than it is for white males. This is the incidence for prostate cancer, the rate per 100,000 that we're seeing in our registry. There's been somewhat of an increase through the early 2000s and then sort of a rollback, but they're doing it in parallel, so there's probably a diagnostic process going on. And if you look at this one, this is the incidence that we're seeing. The incidence difference between whites and blacks is very different than what we're seeing for the mortality. And again, if you catch things early, especially with prostate cancer with localized or regional, your survivals are very good. And if it gets to be distant stage when it's diagnosed, you're down to about 35% survival at 5 years. There is a difference in stage of diagnosis between blacks and whites. 17% of the blacks are diagnosed at late stage versus 12% of the blacks. Again, this translates to nearly a 40% difference, but the numbers are very small, the percentages are very small, so it probably has somewhat of a marginal impact on this. So there are other things going on and other risk factors going on. These are the survivals. As you can see, the whites are doing much better than the blacks with survival from prostate cancer, but we don't see any of the precipitous drops that we saw for the other cancers, especially for lung cancer. And this is how it lays out for the prostate cancer mortality rates by county. We see a bit of a delta effect. The correlation between the prostate cancer deaths in the counties by population, black population, accounts for about 30% of the prostate cancer deaths. But we also have prostate cancer deaths in somewhat hot spots in different parts of the state. Even though we only have a few of these counties, we have a cluster of these counties, so they're the second to the highest level here. So again, it requires a broader view of looking at interventions than just black and white. Closing comments, I'd like to say first, we've only scratched the surface here by looking at 4 cancers. We looked at one that was clearly based on the underlying disparity was by gender, which was lung cancer, and 2 were by race, breast and prostate cancer, and 1 was by gender and race, which was colorectal cancer in actually black males. And one question we need to ask is what is the right comparison group? Should we be satisfied to have the black population or the other disparate population, the low-income whites, come down to the majority white population, or should we be aiming at a better target to look at the best state in the country? An example of this in the European Union is that Greece has half the rate of the rest of the European Union for stomach cancer and for colorectal cancer. And I guess so there must be something said to olive oil and the Mediterranean diet and feta cheese that comes along with that. But should we be satisfied to be the same as Germany or France or what have you if we were in the European Union, or do we want to have the cancer rate for stomach and colorectal that Greece has? I would argue that we should follow Greece in this case. We shouldn't follow Greece in the way they pay their income taxes, but we should follow them in looking at how they're doing with their diets. The Arkansas Department of Health is looking at mapping, and this is mainly being done by Dr. DeLongchamp. And what happens when you look at these things by counties, you're using a rather blunt instrument. Because in every county, if you slice it up into small sections like zip code blocks, there's always a better than middle class section of the county, a lower middle class, and then a very low income class. And when you put them together in the counties all are sort of like woebegone. They're all a little bit above average. So what you need to do is you have to split them out so we can look and find out where the very impoverished populations are throughout the whole state, and then target interventions for them. So we're working on that so we can look at income, education, and access to medical care. So obviously there's a long road to go here, and I just wanted to give you the population overview and the public health approach of how we're trying to look at these things. Thank you.
Thank you, Dr. Reeve. We're going to take questions first from the distant sites. So if there are any questions, we're going to take those first from the field, from any of the 34 distant sites first.